Welcome back to Clinical Med Ed. This is part one of the three-part series on hyponatremia, the most common electrolyte disturbance you will meet in internal medicine, and the one which trainees and physicians most often get wrong. In part one, we lay the conceptual foundations of hyponatremia, including pathophysiology, the common causes, and the classification. Part two of this series will cover the diagnostic approach, and part three will cover the management. So let's begin. 4 learning objectives for part 1. By the end, you will grade hyponatremia by severity, distinguish tonicity from osmolality, recognize the pseudohyponatremia at a glance, and classify any hyponatremic patients into right tonicity and the volume bucket. Part 2, which is the next video, will build on this with full diagnostic algorithm and the SIADH workup, while part 3 closes with management, including hypertonic saline and the osmotic demyelination cliff. Hyponatremia is divided into 3 severity bands: mild with serum level of 130 to 135, often asymptomatic, is picked up usually on routine labs. Moderate, 125 to 129, presents with non-specific symptoms: nausea, headache, malaise, a bit of confusion, but especially falls in the elderly. While severe hyponatremia, which means serum level of less than 125, can present with very profound symptoms like seizure, obtundation, and here we are talking about the possible use of hypertonic saline territory. We'll come to that in our management module. But remember, the number alone doesn't matter that much. It's the rate of drop which matters more, because a chronic hyponatremia patient with 122 may be just functioning independently, while a patient with acute drop 128 may present with seizures. So our anchor case, a 78-year-old nursing home resident, has been brought in to the hospital with a 48-hour history of progressive confusion, anorexia, and one unwitnessed fall. There is no history of fever or any other neurological symptoms. She is a hypertensive and she has been on a thiazide diuretic for nearly 6 weeks. Otherwise, she is type 2 diabetic and has got mild cognitive dysfunction at baseline. Clinical examination reveals that she is drowsy but oriented to person only. She is normotensive without any postural hypotension on the workup. Her mucous membranes are moist. The JVP is not raised. There is no peripheral edema, and the chest is clear to auscultation. Serum sodium is 118. The rest of the chemistry is in front of you, which is relatively unremarkable. The key question is, what is the most likely mechanism of her hyponatremia, and which single investigation will most rapidly narrow your differential diagnosis? 3 numbers to remember: 15 to 30% prevalence among hospitalized patients, as we discussed before, roughly 3 times the mortality risk independent of any other underlying disease, and it's the single most electrolyte abnormality in medicine, yet it's chronically under-recognized by most physicians. Now, the symptoms can be very non-specific, like confusion, falls, anorexia, lethargy, malaise, and it can be attributed to just patient's age or sepsis or baseline cognitive dysfunction. Mild cognitive hyponatremia is never trivial because it doubles the falls risk, the mortality, the cognitive decline, and also drives the bone loss. It can lead to osteoporosis. Osmolality and tonicity, they sound similar and interchangeable, but they are not. Osmolality is the total solute concentration based on sodium, glucose, urea, mannitol, anything which can be dissolved, and it's measured by the freezing point depression. However, on the other hand, tonicity is effective osmolality. The osmoles, the molecules which stay in one particular side of the membrane, and they lead to the water movement with them. That's why the sodium counts, the glucose counts, but the urea, because it equilibrates across the membrane, it doesn't lead to the tonicity. In the clinical situation, the hyponatremia symptoms come down to the low tonicity. So if there is low sodium, that will lead to the water sucked out of the vascular space into the brain cells, and that leads to the problem. Hyponatremia is a water problem, not a salt or a sodium problem per se. The total body sodium in most hyponatremic patients is either normal or near normal. The abnormality is the excess water, which drops the concentration of sodium, and that leads to hyponatremia. So it's held on to by the inappropriate ADH activity. Hence, you trace the pathway, you find the cause. Usually the trigger, which is the rising osmolality or low effective circulating volume, or ECV, it activates the hypothalamic osmoreceptors and baroreceptors, which leads to the posterior pituitary release of antidiuretic hormone. So look at the name, antidiuretic. So hormone which leads to reduced excretion of water. So ADH binds to the V2 receptors in the collecting ducts of the kidneys. It inserts the aquaporin in 2 channels, which leads to the water being reabsorbed. So ADH is a final common pathway in almost all the causes related to hyponatremia, whether it's hypovolemia, SIADH, heart failure, cirrhosis, thiazide diuretics, all of them usually converge here. So once you understand the ADH, you understand hyponatremia. Calculated serum osmolality uses the formula 2 times sodium plus urea plus glucose, all in millimoles per liter. It gives a quick bedside result. The normal range is 275 to 295 milliosmoles per kilograms. For the true value, you need the calculated lab result for the serum osmolality, which actually calculates and detects all the other solutes in addition to the common ones. So the gap between the measured and the actual should not be more than 10. Anything above 10, you think about the unmeasured osmoles. Think of the toxic alcohols like ethanol, methanol, ethylene glycol, mannitol, glycerol, and also severe acidosis and hyperlipidemia. Pseudohyponatremia is an isotonic hyponatremia, and it's not a true reading, it's a lab artifact. The 3 main conditions causing it are severe hypertriglyceridemia due to chylomicron levels being high, paraproteinemia due to multiple myeloma or Waldenstrom's macroglobulinemia, and also hyperproteinemia due to any reason which raises the albumin or globulin levels. So the indirect ion selective electrode method assumes the normal proportion of plasma, which is around 93%, 7% are the non-aqueous component. So because it involves dilution method, so when it dilutes, it assumes that the proportion is normal, which now it is not, because the non-aqueous component may be higher than 7%, 10, 15, 20, 30, whatever. And with that assumption, the calculated sodium level becomes low. What is the gold standard treatment? Our gold standard etiology, our Aurum beetle, gold standard beetle. So you need to use the direct ISC method, which is through blood gas analyzer, and that gives the correct reading. So if you have a clinical scenario with abnormal lab result but a normal sodium level at in the VBG sample, that clinches a diagnosis for USMLE and MRCP exams. Classification of hyponatremia by tonicity. Serum osmolality is the first branch point in any hyponatremia workup. 3 buckets: the hypotonic, which is the true hyponatremia, which means less than 275 milliosmoles per kilogram of osmolality. This is the clinically most relevant form, which is the bulk of this video. And we subdivide it into different parts by volume status in part 2. The second one is isotonic hyponatremia with osmolality of 275 to 295, which we discussed in our previous slide, which is the pseudohyponatremia. And it is a lab artifact we have already discussed. The third one is hypertonic hyponatremia, which we are going to discuss in the subsequent slide. The most common example is hyperglycemia, and you treat the glucose and the sodium follows. Hypertonic hyponatremia, predominantly it's when the serum osmolality is above 295 but the sodium is low. The problem is not sodium, the problem is the permeation of the compartment with water due to effective osmoles like glucose, sorbitol, mannitol, which are ineffective, so they do not cross the membrane, hence they pull water with them. So that's the problem. So similarly, in DKA, HHS, uncontrolled diabetes, all these conditions, they lead to dilutional hyponatremia or translocational hyponatremia. Other causes are mannitol, which is used in neuro-ICUs to improve intracranial pressures, glycerol, sorbitol, and sometimes glycine, which is used in the TERP irrigation in urology wards. And that is also absorbed and leads to severe hyponatremia. When hyperglycemia coexists with hyponatremia, you must correct the sodium for the glucose effect before deciding whether it's a true hyponatremia or not. And for that, we use Hillier's formula, which is corrected sodium equals the measured sodium in serum plus 2.4 times the value that you get from glucose in excess of 5.6 millimoles per liter divided by 5.6. And remember, this is units per millimoles per liter. So look at the example with a patient of sodium 124 and a glucose of 28 millimoles per liter. Once you do the calculations, you will realize that you need to add 9.6 millimoles or almost 10 millimoles to the correction, which means the sodium should be 134 millimoles rather than 124, which is nearly normal. So Hillier's replaced the old CADS formula or the CADS factor by of 1.6. So both appear in both MRCP and USMLE exams. So please remember this. And again, this is our Argentum dove. AG dove should remind you of the balance between adjusting the sodium for glucose concentrations. Once the hypotonicity is confirmed and there is hyponatremia, which is a true hyponatremia, we have three buckets: hypovolemia, hypovolemic, euvolemic, and hypervolemic. The hypovolemic bucket includes when there is reduction in both water and sodium, but predominantly in sodium. Anything like dehydration, GI losses, burns, third spacing, diuretics, adrenal insufficiency, all of them will come into it. Patient will be clinically dehydrated. The second in the middle is the euvolemic phase. The patient clinically looks normal, but there is inappropriate water which is held. SIADH is the commonest, but also hypothyroidism, glucocorticoid deficiency, primary polydipsia, and the reset osmostat are examples. The third one is hypervolemic. As the name says, the water retention exceeds the sodium retention. That leads to the drop of sodium due to dilation. Any volume overload conditions like heart failure, cirrhosis, nephrotic syndrome, advanced renal failure. Clinically, patient will have edema, raised JVP, bibasal crackles if there is heart failure, etc. Volume status assessment is a crucial clinical skill for any physician or trainee. And there are four pillars. Vital signs, postural hypotension and tachycardia are one of the key features indicating hypovolemia. Frank hypotension can be a very late sign in a decompensated phase of hypovolemia. JVP and skin. So raised JVP with peripheral edema can indicate volume overload, while collapsed or flat JVP with reduced skin turgor can indicate hypovolemia. Now, mucous membrane examination of the oral mucosa and axillary dryness can indicate hypovolemia, although it can be unreliable in geriatric population. Urinary sodium, the gold standard, our AU Beetle guides us to that. So if it's less than 20 millimoles, it means the kidney is avidly conserving sodium and hence with it the water, which indicates hypovolemia. It's an appropriate response to restore the effective circulating volume, the ECV. On the other hand, urinary sodium above 40 indicates that there are renal losses of sodium, which can be due to SIADH, diuretics, or salt wasting, which can be primary nephrogenic problem or secondary pathology driving the kidney. So again, no single investigation is gold standard. You have to combine all of them together to get a clear picture. This is one of my very favorite slides: hypovolemic, hypotonic, hyponatremia. It is actually divided by the urinary sodium. We touched upon it in the previous slide as well. So please pay attention. Urinary sodium of less than 20 means the kidney is appropriately retaining sodium, which is the correct thing to do physiologically. So this means the losses of sodium is not renal, it's extrarenal. So what are the other sources of loss? The commonest is gastrointestinal tract, vomiting, diarrhea, any cause. Skin loss due to burns or sweating. Third space loss is like pancreatitis or ileus, which is extravascular correction. Then hemorrhage as well. Now, if the urinary sodium is above 40, this means the kidney is now losing sodium, which can be a primary intrinsic renal pathology or something driving the loss of sodium from the kidney. So the commonest thing here would be the diuretics, for example, thiazide diuretics. Similarly, mineralocorticoid deficiency and salt wasting nephropathy, which is a primary renal problem, and cerebral salt wasting in any neurosurgical patients or intracranial pathology events that can lead to loss of sodium by the kidneys through cerebral mechanisms. Now, in this situation, also remember, do not miss Addison's disease, because Addison means if there is primary adrenal insufficiency, that leads to both aldosterone deficiency, which leads to, because remember, aldosterone was to retain sodium and lose potassium. If there is deficiency, potassium will be retained, sodium will be lost, and also there will be signs of hypotension and pigmentation. And so that indicates Addison's disease. And also the cortisol deficiency can disinhibit ADH, so that also complicates the picture. So the full picture, as we have discussed, is hyperkalemia, hyponatremia, hypotension, and sometimes pigmentation. Now remember this very good example here about vomiting. So the vomiting can be a trap in your MRCP, USMLE exams. How? In vomiting, the body is losing in hydrogen and chloride. So hydrochloric acid is lost from the stomach. Chloride is lost, hydrogen is lost. So what will be the neutrality principle? The body will lead to metabolic alkalosis. So bicarbonate will be high. Now to maintain electroneutrality, the kidneys will have to lose bicarbonate. So that will lead to bicarbonate urea. Because bicarbonate is negatively charged. So it has to be accompanied by a positive ion. So that will be either sodium or potassium. So in this situation, despite volume loss, it's hypovolemic, the urinary sodium can be above 20. Now, urinary chloride is the best investigation in such situation because in vomiting and GI loss, the loss of chloride will be compensated by kidneys retaining the chloride, which means there will be less urinary chloride. So urine will be less than 20 millimoles per liter. In primary renal loss of salt, the urinary chloride will be high. For example, active diuretics or tubulopathies. In that situation, chloride will be above 20 millimoles per liter. In a hypovolemic patient with a high urinary sodium, there are four main mechanisms to drive the renal sodium loss. First of all, diuretics, which is a very, very common occurrence. Thiazides, they induced an SIADH-like biochemical picture, and also they lead to mild volume depletion, which leads to secondary release of ADH, and hence that leads to sodium loss. Loop diuretics cause more direct sodium loss with impaired urine concentration. Second is mineralocorticoid deficiency. So in Addison's hypoaldosteronism, sodium is lost, potassium is retained, and also leads to mild acidosis. And short synectin test and random serum cortisol can support the diagnosis. Third is a salt wasting nephropathy. Any tubulointerstitial disease, analgesic nephropathy, chronic reflux, polycystic kidneys, any patient with mild CKD, even older adults can have salt losing nephropathy conditions. And fourthly, cerebral salt wasting, any intracranial event, subarachnoid hemorrhage, traumatic brain injury, neurosurgical procedures, they lead to a SIADH-like condition that leads to sodium loss. For euvolemic hypotonic hyponatremia, there are four main differentials which sit under this pillar. SIADH is by far the commonest, and usually people attribute hyponatremia to SIADH, but it has to be the diagnosis of exclusion. We will come to that later. Always exclude the other three before ruling in SIADH. Hypothyroidism, typically severe disease, myxedema territory. We are not talking about subclinical or mild hypothyroidism, which can lead to hyponatremia or moderate or severe hyponatremia. Glucocorticoid deficiency, so secondary adrenal insufficiency from pituitary disease or chronic steroid withdrawal. The cortisol deficiency disinhibits the ADH, so that leads to hyponatremia. Random serum cortisol or 9 AM cortisol plus minus short synectin test will be confirmatory. Primary polydipsia, one of the very favorite exam questions for MRCP and USMLE. The water intake exceeds the renal excretion. So what happens? It's usually due to psychiatric conditions or elderly with cognitive impairment. The key discriminator in such situation is the urine osmolarity, because the ADH will be appropriately suppressed, and that will lead to maximally dilute urine with a urinary osmolarity of less than 100 milliosmoles per kilogram. The discriminator between primary polydipsia and SIADH is actually urinary osmolarity, because in SIADH, it's inappropriate ADH secretion, which leads to retention of water, hence lower plasma osmolarity, but higher urine osmolarity. Definitely above 100, most often above 300 milliosmoles per kg. Let's look at the Bartter and Schwartz criteria for SIADH developed in 1967, and these still remain examiner's reference guide. All 6 requirements must be met. Number 1, true hypotonic hyponatremia, which means a plasma osmolarity should be less than 275. Number 2, the urine should be inappropriately concentrated, which means the urinary osmolarity should be above 100. Mostly it's above 300. Number 3, the patient should be clinically euvolemic. Number 4, urinary sodium should be above 40 millimoles per liter on normal salt intake, which means kidneys are inappropriately excreting sodium. Number 5, you have to exclude hypothyroidism and adrenal insufficiency. And number 6, finally, do not forget about looking at the drug use, diuretics, for example, especially thiazide diuretics. Now, if you miss any of the criteria, then SIADH is the wrong label. How many times in admission we see residents saying hyponatremia due to SIADH? You can barely diagnose with confidence on the day of admission. It's a diagnosis of exclusion, not a diagnosis of inclusion. And for your learning, remember our ORM AU Beetle, reminding you of the gold standard criteria to diagnose SIADH. Causes of SIADH. Remember 6 main categories. Number 1, CNS, starting from the top. Stroke, hemorrhage, meningitis, encephalitis, any intracranial acute etiology, or chronic, for example, trauma or tumor or subarachnoid hemorrhage, anything, any irritation of hypothalamus or stalk. It's a very important cause. Pulmonary etiology. Pneumonia is a very common case. Any intrathoracic abnormality, COPD, exacerbation, asthma, Legionella, atypical pneumonias, TB, abscesses, severe asthma, or anyone with invasive or non-invasive ventilatory support. Malignancy, small cell lung cancer is a paradigm of ectopic ADH secretion, so please do remember that. Also head and neck, GI, or genitourinary malignancies. Drug category, extremely important, very common, especially in elderly population. Diuretics, antipsychotics, carbamazepine, oxcarbazepine, MDMA in young patients, ecstasy, recreational drug use. There's a separate section for this drug-induced SIADH. A lot of surgical consultations to our medical registrars come that with a low sodium on day 2, day 3 post-operative. So again, very common causes: pain, nausea, opioids, hypotonic fluids, iatrogenic, classic textbook combination, but it can be really important if it's missed. And others, idiopathic category, or generally also atypical infections, opportunistic infections like HIV, hereditary nephrogenic SIADH, exercise-induced hyponatremia, and endurance athletes. So hypervolemic, hypotonic hyponatremia. There are 4 classical causes. All of them share one basic pathophysiology, which is low effective circulating volume, which is low ECV. What does it mean? There is fluid overload, but the ECV is low. Think of it like, a sailor on the sea. There is plenty of water around, but the sailor cannot drink water because it's not appropriate. So there's plenty of volume, but it's in the wrong place. There's fluid overload in the body, but it's not in the circulation. So that leads to the problem. Heart failure. Forward flow is inadequate. There are better receptors in the carotids. They sense that there is underfilling that leads to CNS release of ADH, which eventually leads to volume, water retention, and volume overload. Remember, hyponatremia correlates inversely with mortality and heart failure. Number 2, cirrhosis. There is splanchnic vasodilatation that leads to increased capacitance of the vessels, and that is despite ascites. So it's extra vascular sequestration of fluid. It's in the wrong place. So then the same thing happens. The ADH is released, retention of salt and water, more water retention, hence that leads to hyponatremia. And this leads to hepatorenal syndrome and decompensation. Third, nephrotic syndrome. Heavy proteinuria. There is loss of albumin leading to hypoalbuminemia, which leads to reduced oncotic pressure inside the vessels. That leads to fluid redistribution, and the effective volume falls. Again, ADH is activated, leading to hyponatremia. Advanced CKD, very important. Once the eGFR is critically low, less than 15 ml per minute of the 1.73 meters square of the body surface area, the kidneys cannot excrete a water load. One of the key functions of the kidney is, fluid balance. So this is particularly dangerous if patients can continue to have high fluid intake. We'll come to some treatment in some other module. Now, all 4 causes are dilutional. So this means there is total body sodium is actually elevated, but there's plenty of water, which leads to the drop in the concentration of the sodium and hence hyponatremia. So here the treatment is not raising the sodium. The treatment is rather restricting water or removing excess water from the body. What is effective circulating volume? Now, this is a concept which ties the hypervolemic hyponatremia together. We are talking about the volume of the plasma or volume of the circulation, which is actually inside the vasculature. So that's the simplistic definition. The volume which the kidneys baroreceptors and the body's baroreceptors sense inside the circulation, that is effectively calling the shots, should we say. It's not the total body water. Now, in heart failure, cirrhosis, and nephrotic syndrome, what happens? The blood pools or leaks into the interstitium, which is extravascular space. That leads to the underfilling of the intravascular space, and then the arterial baroreceptors sense that as if there is volume depletion. That leads to hypothalamus releasing ADH, and then renin-angiotensin-aldosterone system is activated, sympathetic system is activated. This finally leads to sodium and water retention, but the water retention part is far greater than sodium retention. That leads to dilutional hyponatremia. Now, when the patient looks fluid overloaded, when you look at the patient, there is plenty of water, but it's in the wrong place. The kidneys behave as if it's volume depleted. That's the paradox. And the treatment here is not to raise the sodium by giving more hypertonic saline or even normal saline. Rather, you need to remove the fluid by either diuretics or fluid restriction or both. Thiazide-induced hyponatremia is one of the commonest drug causes of hyponatremia, especially in the elderly population. The mechanism is multifactorial. Thiazides block the sodium chloride co-transporter in the distal convoluted tubule, which leads to mild volume contraction, and hence the baroreceptors trigger the release of ADH and eventual hyponatremia. They also impair the urinary dilution directly. Plus, due to the hypokalemia caused by these thiazides, it can further complicate the picture. The classic presentation is our elderly female patient who is often very slim, low oral intake, low solute intake, and recently started by the GP or a healthcare provider on a thiazide diuretic, has been on a few other medications, and within two weeks to 2 months just presents with atypical symptoms and falls and confusion and incidental diagnosis of hyponatremia on labs done. SSRIs in combination with thiazides carry a particularly high risk of hyponatremia. What is the management? Of course, stop the medication, the thiazide. And also, if the patient is mildly symptomatic or asymptomatic and the sodium is above 125, then reduce the free water intake to around 1 to 1.5 liters, depending upon the body habitus, etc. Do not re-challenge with thiazide again, and consider, because the recurrence rate is very, very high, and switch to a different class of drugs like calcium channel blocker or ACE inhibitor. Biochemically, the thiazide hyponatremia can be indistinguishable from SIADH. The key distinguishing factor will be the temporal association of the clinical history from the timing of the drug, the demographic. That is the key discriminator. The drug-induced hyponatremia goes well beyond thiazide diuretics. The following 6 high-yield categories can be crucial. Number 1, SSRIs and SNRIs, which include the selective serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitors. So the drugs are like sertraline, citalopram, venlafaxine. They can produce SIADH, and typically the symptoms can occur within 2 to 4 weeks of initiation of medication. That's why the drug history is so crucial. And the risk is compounded if the patients are already on thiazides. Coming to carbamazepine, its analogs, they can lead to dose-dependent SIADH release. And again, because of the same problem, it can lead to hyponatremia. That's why routine sodium monitoring in such patients is really crucial, especially if the escalation and titration of the dose is needed. Coming to chemotherapeutic agents, we don't usually attribute them to hyponatremia, but the chemotherapy-associated hyponatremia is basically a 3-mechanism problem. Number 1, SIADH, which is the predominant one from the drug itself. Number 2, the neuroendocrine effect, the renal salt wasting from tubular toxicity, and also the dilution due to aggressive prehydration. So what actually happens, drugs like cyclophosphamide, especially in high doses, Vinca and platinum agents, they can activate ADH directly, and they can also lead to renal salt wasting. Now, a lot of chemotherapeutic oncology practices aggressive prehydration. When there is aggressive prehydration on top of an acute SIADH causing drug, this is a full cocktail for an acute hyponatremia, which can be very, very dangerous. Number four group is the antipsychotics, very, very common. Older typical phenothiazine drugs, risperidone, and it's confounded by patients who have compulsive or primary polydipsia, which again leads to the 2 mechanisms combining and leading to hyponatremia. A very, very interesting MRCP and USMLE question is the ecstasy hyponatremia. which is the street name. So MDMA, the recreation drug usually used by young adults in music festivals and parties. It can lead to direct ADH release, which can lead to hyponatremia. The other main problem is MDMA can lead to severe thirst mechanism, and that leads to deliberate water loading. It leads to extremely dry mouth. And that again can be a fatal combination when both combined will lead to acute hyponatremia. So usual patients presenting from party with seizures and altered obtundation, altered mental status and sensorium, etc. Lastly, the non-steroidals and opioids, they potentiate other causes. NSAIDs block the prostaglandins, which lead to impaired free water excretion, and hence that leads to hyponatremia. And opioids, they stimulate ADH directly. So any patient on surgical ward, medical consultation team is called to see the patient due to hyponatremia. Always remember to check the medications. Plus, the patients usually have nausea, pain. That can also lead to SIADH. Primary polydipsia versus SIADH. These are the two euvolemic conditions of hyponatremia. So the single most discriminatory test is urine osmolality. In primary polydipsia, the patient drinks excessive water so that the kidneys have to excrete sometimes like 10 liters per day. Now in this situation, ADH will be appropriately suppressed because the body wants to get rid of the excess water. So if that is the case, what will happen? The urine will be maximally dilute and the osmolality will be less than 100 milliosmoles per kilogram, because the kidney is doing its job. That is what it's supposed to do, to excrete the excess water. The problem is input, not the output. And in SIADH, the opposite occurs, because the ADH stays in inappropriately, not physiologically. The urine has to be concentrated because it's anti-diuresis. The name is the answer. So anti-diuresis means the body is trying to conserve the water, and the serum osmolality is low, which means it's dilute, while the urine becomes excessively concentrated. So the osmolality in urine is usually above 100, but mostly above 300, as we discussed previously. So there is another entity which is called reset osmostat. It's important to understand. It sits in between the two. It's neither polydipsia-like picture where the ADH is totally suppressed, nor it's SIADH-like where ADH is constantly switched on. So in elderly, chronic medical conditions, patients with pulmonary problems, malnutrition, advancing age, dementia, the body tries to protect the brain from excessive, fluctuations in ADH level and excessive changes due to the sodium. So they try and lower the threshold of ADH response to hyponatremia, and the usual sodium stays stable between 128 to 130, 132, and there is no treatment required for such conditions unless there is an associated compounding problem with that. And so chronic stable hyponatremia, mild, not much symptomatic unless there is another reason. It just needs strong, close monitoring and look for other causes, look at the drug history, etc. So in terms of examples, coming back to primary polydipsia versus SIADH, the key single discriminatory test is urine osmolality. If the urine osmolality is low, that's primary polydipsia, which is the appropriate response. If it's high, that means it's SIADH and concentrated urine. Now, the acute versus chronic hyponatremia, it's a very, very important clinical discriminator, the 48-hour rule. If the confirmation of sodium level is within 48 hours and you have an absolute clear concern that the previous sodium level was normal, that is acute hyponatremia, especially if it is symptomatic. But if it's beyond 48 hours or you're not sure and it's, patient is stable, mild symptoms, nothing major, assume that it's a chronic hyponatremia until proven otherwise. So in acute hyponatremia, less than 48 hours, because the sodium is lower extracellularly, the brain cells had not had time to adjust or remove the osmolytes out of the cells. That means now the dilute extracellular compartment, the water from that will be sucked into the brain, and that can lead to cerebral edema. That can be life-threatening and dangerous, and symptoms can be very severe: seizures, obtundation, coma, etc. That's why rapid correction will be with hypertonic is life-saving in this situation and brain-saving. In chronic hyponatremia, beyond 48 hours, the opposite occurs. The brain has adapted very slowly, very nicely to this chronic hyponatremia. That's why all the osmolytes, the sodium, potassium, organic solutes, they have been adjusted intra and extracellularly. That leads to patient being surprisingly stable at a relatively lower or chronically lower sodium levels. So do not be aggressive in treating such levels. In fact, the rapid correction in this situation can be a killer in this situation, and that can lead to osmotic demyelination syndrome and irreversible damage. And maximal correction usually in such situation, if it's really indicated, is 8 to 10 millimoles per liter in any given 24-hour period. We will cover all this osmotic demyelination and rapid correction versus slow correction in our part 3. However, please follow your local protocols, local guidelines, and individualize each patient according to the clinical presentation, confirmation of investigations, and this guidance is only for educational purposes, not a definitive treatment for patients with hyponatremia. So coming to our case 1, which we discussed at the start of the video. Serum osmolality 248, which is low, which confirms hypertonic hyponatremia. Let's look at the urine osmolality 412, above 300, highly suggestive of ADH being active, which it shouldn't be. So it's ADH driven. Urinary sodium 52 means the kidneys are losing sodium, so not retaining. Look at the thyroid function, TSH, and 9 AM cortisol being normal. So both very important etiologies to exclude for you to establish SIADH as a cause we discussed earlier. Now, it looks like SIADH, but our last criteria out of the 6 was to look at the drugs, especially thiazide diuretics, which this patient has been on for 6 weeks. So this produces an SIADH-like biochemical picture, but the demographics fit with the thiazide diuretic picture because she has been on the medication. Now, you might say, is it pure thiazide? Is it SIADH related? Or is it both? Part 2 of this series will cover and will answer this in more detail. For now, please hold on to the picture. Euvolemic biochemistry, which is hypotonic. You've got concentrated urine and high urinary sodium and on a thiazide. Now, the 6 key takeaway pearls from part 1 covered with our MedEd quartet. So, the Argentum dove, aurum beetle, techian, and brady. So, first of all, the rate of hyponatremia matters more than the absolute value. So, an acute drop to 128 is more dangerous than a patient with a chronic level of 118. We've already covered this. So, again, this is crucial. Number 2, tonicity and osmolality are not the same thing. The urea raises osmolality without raising tonicity, and that distinction drives every diagnostic decision. So please remember that. Number 3, always measure serum osmolality first. It is the first branching point of differentiation of your, the osmolality based on the tonicity based on, hyponatremia. Is it hypotonic? Is it hypertonic, or is it isotonic? And the true hyponatremia is hypotonic, and the next step will then be to assess the volume status of the patient. If it's true hypotonic hyponatremia, the clinical bedside examination of the volume status, postal blood pressure, mucous membranes, JVP, we have discussed about it, and that is really, really essential. And then urinary sodium does most of the work of differentiation between appropriate or inappropriate conservation or loss of sodium. And 5th, which ties in with all the 3 states, osmolality, volume status, etc., is the ADH. ADH is at the center of most hypotonic hyponatremias. We have discussed about it before, whether it's appropriate or inappropriate release, or it's extravascular volume overload like heart failure, cirrhosis, plus drugs. So all of them lead to and converge to ADH, which leads to hyponatremia as a final mechanism. As a final result from the final mechanism of ADH. And lastly, do not forget about the pseudohyponatremia. We have discussed it before, and also the drug-induced hyponatremia, which we recently just covered. So these are really, really crucial tips to remember. The 3 most important examiner pearls to keep in your pocket, please. First, vomiting trap. The vomiting leads to bicarbonate-urea. We have discussed this before, and the bicarbonate drags sodium with it into the urine. So the urinary sodium can exceed 20 millimoles even with GI losses. So that can be a red herring. What was the discriminator? We discussed is the urinary chloride, because the urinary chloride will stay low because the kidneys are trying to conserve the chloride which has been lost from the stomach. So examiners love this, please. Number two, pearl number two, cerebral salt wasting versus SIADH, another of the exam trap questions. So biochemically, both are nearly identical, but the problem is with the volume status. In cerebral salt wasting, the patient will be volume depleted. While SIADH, it's one of the euvolemic hyponatremic conditions. So classically, the cerebral salt wasting is present in patients with intracranial events like subarachnoid hemorrhage or traumatic brain injury. The treatment is opposite. Because there is volume depletion in cerebral salt wasting, you need to hydrate them, especially with saline. While in SIADH, the problem is not the sodium, the problem is the water, excess water. So what do? You restrict the fluid. That's why the crucial assessment will be, the pivotal point will be the clinical assessment of volume status. And last but not the least is pearl number 3 is the Hillier's correction for hyperglycemia. So you need to, the translocational hyponatremia or the dilutional hyponatremia that needs to be excluded. How many times my residents call me from a surgical ward with hyponatremia, patient is totally well. When we just look at the investigation chart and electronic health records, the glucose is very high. When you correlate it, it becomes relatively normal. So you need to add 2.4 millimoles of sodium to the baseline lab number for every 5.6 millimoles per liter excess glucose on top of 5.6. Okay, so this replaces the older CATS factor of 1.6. Severe hyperglycemia hides the true sodium. It's not the actual hyponatremia. It's dilutional or translocational hyponatremia. And again, always treat the glucose and the water follows. So that's part 1, the pathophysiology, causes and classification of hyponatremia. In part 2, the second video, we will cover the full diagnostic algorithm starting from serum osmolality and urinary sodium, and we will resolve the case once and for all. The part 3, third video, will cover the management of hyponatremia, including hypertonic saline, the safe correction rates, and the osmotic demyelination cliff. If this was useful, please subscribe and ring the bell button for the next 2 videos and for future exciting content. See you in part 2.